We've discussed your shoulder and have decided that arthroscopic intervention is indicated. And I wanted to talk to you about shoulder arthroscopy in general. This is a minimally invasive procedure involving small portals, and we use an arthroscope. An arthroscope is a long, thin instrument that we pass into the joint that allows us to see the inside of your shoulder. The arthroscope is attached to a video camera, which is then attached to a video monitor, and we have 3 monitors in the room, 1 on the wall and 2 overhead monitors, so that everyone in the room can see what we're doing inside your joint, see what the pathology is, and are there able to assist me in the management of the pathology that we identify. Arthroscopy of the shoulder is used to treat a number of different pathologies, in particular rotator cuff tear, labral tears such as slap lesions, bicipital lesions, as well as AC joint problems, impingement. And in terms of arthritis, there's a limitation to what can be done for arthritis. But there are synovial conditions, loose bodies, chondral lesions that can all be treated arthroscopically. When we use the arthroscope to manage your shoulder pathology, you'll need anesthesia. And the anesthesia typically is an interscalene brachial plexus block, which is local anesthetic injected under ultrasound control with a nerve stimulator feedback to be sure that we are getting the local anesthetic into the proper location. And that results in numbness of not only the shoulder but the entire upper extremity. And this is done in the preoperative hold area before you go to the operating room so that there is enough time for the block to set up. And when you get to the operating room, you do have a general anesthetic. And then we position you in the lateral decubitus position. So you are side lying, you're supported, and we use a little inflatable, what we call an axillary float, which keeps pressure off the dependent upper extremity. And then we use what's called a beanbag vacuum pack, which supports the body in that lateral position, rolled back about 10 degrees. And this is to position the glenoid, articular surface, in the horizontal position for orientation. Once we've padded the bony prominences and project your perineal nerve, make sure that the cervical spine is in neutral position, and make sure that there's a comfortable posture, we use venaflows on the lower extremity, which are sequential compression devices to decrease your risk for DVT. And we'll place a bear hugger, which is a warming blanket to make sure that you maintain normal temperature, because we do keep the operating rooms rather cool. The cooler the room, the lower the bacterial count. Once you're fully positioned, shoulder is prepped and draped, and the arthroscope is introduced into the posterior aspect of the shoulder and the joint inspected. We typically use a spinal needle in the front to define the trajectory and location of an anterior portal, make a small incision in the skin, which is about 1 centimeter, pass a switching stick down into the joint, use a dilator, and then pass a cannula into the front of the joint. Now we have both inflow and outflow, and a diagnostic arthroscopy is performed. We inspect the joint. We look at the articular surface cartilage of the glenoid and of the humeral head. The glenoid is on the shoulder blade side and the humeral head on the arm. And that's the articulating surface. We assess that joint surface cartilage. Around the glenoid is the labrum, which is a fibrocartilaginous extension that increases the surface area and provide stability. And it's not uncommon that one can have labral tears that can be addressed arthroscopically. The long head of biceps inserts into that glenoid labrum up at the top, and that can be a source of pain and pathology as well, and that can be treated arthroscopically. In addition, we look at the rotator cuff, including the 4 main musculotendinous units: the subscapularis at the front, supraspinatus on top, the infraspinatus, and the teres minor at the back. This is all assessed both from the posterior perspective as well as from the anterior perspective. We then use small instruments in order to do the intra-articular work. The instruments appear large on the screen due to magnification, but they're typically 3.5 to 4 millimeter diameter instruments. Once the intra-articular pathology has been addressed, we go up into the subacromial space, and we can use the same posterior portal. We can use the anterior portal to access both the joint and the subacromial space, and we use a midlateral subdeltoid portal to get into the subacromial space. We typically use at least 2 or 3 portals when we perform a shoulder arthroscopy, but there are about 9 portals described, and we use whatever portals are required to allow the angle of approach and trajectory of instruments and arthroscope to allow us to do the procedure. That's a bit of an overview of the procedure itself. The specifics of your procedure I'm going to discuss in a separate short video. At the end of the procedure, local anesthetic will be placed in each of the portals, a dressing applied, and we use a DonJoy Ultra Sling, which is a immobilizer with a small pillow that takes some of the tension off the rotator cuff. And we'll use a cryocuff, which is a cooling device to help with pain and swelling control. Postoperatively, you will be provided with medication, which will include mild, moderate, and severe pain medication, along with medication to avoid constipation, and a baby aspirin to minimize your risk for DVT. You will be in the recovery room for a short period of time, and then back to the ambulatory care unit where your family can join you, and you'll be discharged home once you meet discharge criteria later that day. You'll follow up in the office with us the following week, and outpatient physical therapy will be arranged for you. Now, this brief discussion may have raised some questions, and I'm happy to answer them for you.